Hi, my name is Dr. Rudra Mohan, and through the oral health channel today we're going to be talking about Lafort 1 osteotomy. Let's start. So today another series of the orthognathic surgery. I'll be talking about Lafort 1 osteotomy. As I already told, that osteotomy means the cutting of the bone to make sure that you're doing orthognathic surgery. Now if it's Lafort 1, does Lafort 2, Lafort 3 also exist? Yes. Lafort 2 and Lafort 3 are generally used for any sort of craniofacial dysostosis. That means any sort of bone defects or skull defects that might require reconstruction. Lafort 1 osteotomy is typically used for orthognathic surgery purposes. That is, when you have a skeletal malocclusion and a discrepancy between the upper and the lower jaw members, most likely around the midface. Now let me talk about the Lafort lines, and I'm not going to talk about the exact landmarks because this is actually this episode is actually issued for the general public. You have three lines which are Lafort 1, Lafort 2, Lafort 3, and these lines are planes basically which are very susceptible to fracture, and most likely if unfortunately someone goes a facial fracture, these are the three lines where the fracture is most likely supposed to have. So Lafort 1, it goes around here, Lafort 2 is around this pyramidal fracture, and Lafort 3 is around here. So coming to Lafort 1, using these fracture lines as references, now the beauty about surgeons and surgery is that they have come up with better ways to use these fracture lines, these susceptible areas, to create much better maxillomandibular relationships. That means the relationships between the upper jaws and the lower jaws if there is any sort of skeletal malocclusion, such as a deficient maxilla, that means deficient upper jaw member, vertical maxillary axis of the upper jaw member, that is the maxilla. Then you can have you can do a setback and the advancement and both those things of the maxilla. The asymmetry that might be present, and this is also used in creating more volume for the obstructive sleep apnea patients. Usually in cleft lip and palate patients you have a hypoplastic maxilla, that means it is a deficient maxilla, and that's why you might require a Lafort 1 osteotomy to increase or gain some more bone volume or length or height or any sort of width. The beauty about the maxilla is that once it is separated in the Lafort 1 osteotomy, it can move in all the three planes. Now before we even start, we have to do a pre-anesthetic workup and do all the tests possible to deem the patient surgically fit for undergoing general anesthesia, at the same time undergoing any surgery, so they don't have any metabolic diseases such as diabetes, any sort of diseases such as blood disc crisis or disorders that might affect the outcome of the surgery. Once the case has been planned out with the help of the orthodontist and the oral surgeon, and we've put the patient under general anesthesia with all the equipments and all the things necessary, we locally anesthetize the area and give an incision in the from 5 mm from the root apices of the upper teeth into the gingiva and into the vestibular mucosa, creating a sort of a surgical field. After that we do subperiosteal dissection, and then we slowly dissect away all the soft tissues to localize the maxillary bone, that is the upper jaw bone, and we make sure that it is gone all the way to the the most distal, that means the most distant segments possible. Once we have visualized all those things, we start to separate the maxilla with the help of various instruments. Because of the fact that the episode is meant towards the general public, I'm not going to go into the details. You relieve the maxilla from the nasal floor, the base of the skull, and all the other bones, and you create osteotomy cuts. Now osteotomy cuts are used by very special surgical tools known as osteotomes, and you have to be very careful. The surgeons are usually very good at it, and they create these osteotomy cuts and sites to ultimately completely mobilize the maxilla from the rest of the skull, and it can move around in all planes, anterior, posterior, left, right, at the same time. It can tilt and everything, right? So what happens after that, once you've done that and you've made sure that all the soft tissue has been clearly preserved and removed, at the same time all careful blood vessels that need to be taken care of have been preserved and protected, you finally either advance or impact, or you change the cant, or you can cut the little bit of the the free and the mobile maxilla to your whatever surgical need that is required, because vertical maxillary access might require that. a reduction, any sort of forward placement, impaction, can change, and all those things. Now this can also be done in conjunction with the BSSO, that is the bilateral sagittal split osteotomy, for a bi-jaw surgery if you want to completely change the dentoalveolar complex. Before all that, we also do with the braces and all those things, we take a preliminary impression and we fabricate a stent with it, which basically helps in guiding the occlusion. What happens is that whenever you skeletally disimpact the maxillary member from the rest of the face and you put it to the desired position, there might be a chance of some sort of anatomical malocclusion that can be corrected with the help of a splint. Now the splint was placed pre-operatively, so when the teeth come together with the help of a splint, you will have a set malocclusion that was previously achieved, and now in the new position you can put the plates and do whatever advancements or impactions and all those corrections that were required for the maxillary advancement or the surgery, the referred one, osteotomy. Now there are some possible risks which are there for all invasive surgical procedures. There could be vascular risks, anatomical risks, you might have some post-operative sequelae, but the benefits outweigh the risks by a huge margin. And once the patient's swelling goes down after the compression bandage and the surgery is over, about 24 to 48 hours you're not supposed to take any food, you're supposed to take IV fluids, and you're given an intermaxillary fixation so that it stays in position and both the upper and the lower jaw are kept in position so that it takes its good time to heal, and within a few weeks you can start off with softer diets and liquid diets and you can ambulate and all those things. And after all the swelling and everything starts going down, you see a difference which is beautiful, and that really impacts the quality of life. So this was today's episode. Please like, share and subscribe, and do press the bell icon for important updates. If you want to get in touch with me, here are my social media handles and my WhatsApp number. Kindly refrain from calling me directly as I might be busy with patients. Just drop me a message and I can speak to you after some time. And I hope that you like the content that is being produced in these videos. So that's it for today. Thank you.